The webinar. This webinar is update of spine surgery, and this webinar is supported by Middle East Spine Society and WFNS Spine Committee and International Academy of Spine. The topic is cervical spine surgery indication and techniques, and we have 3 experienced surgeons. We will first invite Andrei Joaquim, then Oscar Alves, and last Christopher Ames. And we can start, Andrei.
Hello, thank you for the invitation. It's an honor to be here with giants. And I'm gonna share my screen. Can you see my screen?
Yes, yes, perfect.
Well,
yes, we can see.
I try to be on time, and thank you very much for the invitation. It's an honor to be here. I'm going to talk about cervical laminectomy. I think someone needs to mute the. Okay, thank you. I'm going to talk about cervical laminectomy and discuss a little bit about the indications and the status of the knowledge. What do we know? We know that the normal cervical spine has a little lordosis between C2 and C7, but most of the lordosis is in the upper cervical spine. The mean cervical lordosis is about 16 degrees, but some patients have even kyphosis. Asymptomatic patients may present with some degree of cervical kyphosis. So the presence of kyphosis itself is not a disease. And there are many forms to measure the cervical lordosis. The most used for sure is Cobb angle between the inferior end plate of C2 and upper end plate of C7. The benzo line is very interesting because you draw a line from the posterior inferior aspect of C2 to the posterior inferior aspect of C7, and no other vertebrae can cross this line. It's not a measure, but it indicates if the spine is straight or not. And the Jackson line is also used in some studies and papers. It's a line from the body of C2 and the body of C7. The bisection of these lines give you an angle of lordosis. So you can evaluate the lordosis using different forms. And we know that an unbalanced spine, and most of this knowledge comes from the thoracolumbar spine, they affect cervical alignment. You can see here that when we have a sagittal imbalance with reduction of thoracokyphosis and also reduction of lumbar lordosis, we may have a compensatory hyperlordosis. We also have hyperlordosis in some craniocervical junction kyphosis, such basilar invagination. So the spine is linked together, and we're gonna see this in details. I love these pictures. I used to show them to the patients. It's a picture from physiotherapists, most of the websites from physiotherapists. It provides some illustration that if your head is bending forward, the weight of your head increases and the amount of muscle recruitment increases. So this patient here have a heavy head, and he also had some neck pain because your muscles need to be stronger. You recruit your muscles. So I like to show these pictures to the patients to explain this. And it's necessary to have a comprehensive evaluation. Unfortunately, most of the times we have to do not only an MRI, but also dynamic X-rays. Here you can see I have a couple of cases that you note an instability in dynamic X-rays. You can see a clear mobility between C3 and C4. The CT scan is important for evaluation of OPOL. I think it's the best exam to OPOL that can change your approach most of the times, but also for your planning, your instrumentation. For you evaluated your C2, your C7, the size of your lateral mass. I think CT scan is important to evaluate your surgical plan. But the most important exam for sure to evaluate the cervical spine degenerative disease is an MRI. An MRI, you can see the amount of compression, the site of compression, the number of levels compressions. And it's important, I used to say to my residents, to take care of about evaluate the lordosis with an MRI. MRI is not to evaluate the cervical spine alignment. I think it's better to have simple plain X-ray, because sometimes you don't know how the exam was done. Sometimes they can bending the head forward, using some pad in the head. So to evaluate the alignment, it's better to use cervical X-rays. And Dr. Ames is here. I think he's going to talk this much better than I, but it's important to know that the plumb line of C2 over C7 provides a clinical objective parameter of how much your head is bending forward. It's known that when your plumb line of C2 is more than 4 centimeters from the plumb line of C7, this is associated with unfavorable neck score index and poor quality of life. And also T1 slope that I'm going to talk in details, that this is important, and the chin brow angle that we need to look in the horizontal. We cannot look into the floor. When we look into the floor, we need more muscles to maintain the normality. This patient, for instance, you can see the chin brow vertical angle, the horizontal, the vertical plane, and the chin brow line. She is looking to the floor. So we have to normalize this, because when you look to the floor, you have neck pain, you can worsen your neurological symptoms. So this is a problem. And we have to correct this most of the times with osteotomies, that it's not the objective of my presentation. And what we know now that the cervical junction is of paramount importance to understand the alignment of the cervical spine. The cervical thoracic junction gives you the amount of lordosis you need to have. How does it work? The T1 slope, it's an angle that it's made by the horizontal line and the superior end plate of T1. If you have a high T1 slope, it means that you have a kyphotic thoracic spine. You need much more lordosis than a patient with a low T1 slope. This is to achieve balance. There are many mathematic schemes in the literature to attest this, and I'm going to talk about only 2 papers that evaluated the outcome of patients. If you have a T1 slope minus C2, C7 lordosis less than 20 degrees, it matches. What means it matches? This patient is balanced. If you have a T1 slope very high and you don't have a higher lordosis, you have neck pain, poor neck disability index. So if the patients match, they have better outcome than patients with unbalanced relationship between your T1 slope and your lordosis. This is another paper that provides the same conclusions, that if you have a mismatch, your plumb line is also poor and the neck disability is poor. So you have to consider the T1 slope when choosing for anterior-posterior approach, or even to know if it's a deformity or a simple cervical case. These 2 pictures are from the manuscript, not mine. And then you can see here that this patient have a mismatch, and it was correct in the post-operator to less than 20, and the neck disability index is good, less than 25 is good. And this one, there you can see a higher mismatch, you can see a high T1 slope and low cervical lordosis. The neck disability is pretty bad. So it's important to understand T1 slope. Here it's a case of mine of a simple exam. If you look just the MRI in this case, I am pretty sure that you can equipoise. You can go anterior or you can go posterior, because you see that there is cervical lordosis. But if you take a look at in the thoracic spine, this patient has instability and a high T1 slope. So it's my preference to go anterior to do a less morbid procedure instead of a deformity surgery. Consider the T1 slope. This is especially important for cases like this, that it's not the theme of this presentation, a severe T1 slope due to fracture that we have to correct with multiple osteotomies and to try to avoid a near normal alignment. Specifically talk about cervical spondylotic myelopathy. The objectives of our surgery to avoid progression and to improve neurological recovery, consider these new radiological parameters. And when we're going to decide the treatment, we have to see, as I mentioned with the MRI, the compression is anterior or posterior, it's a focal compression or multiple compression. How is the cervical alignment and other parameters? Do you have instability in previous surgeries? And if the patient is able to tolerate the surgery. As a general rule that
Andrei, we cannot hear you.
Andrei, you can open your voice.
Sorry.
Okay.
Sorry. Is laminectomy dead? I don't think so. I think that in some very specific case of good lordosis, good cervical parameters in older patients, laminectomy can be considered. And laminectomy with posterior fusion, if you have a good alignment, it requires multiple level surgery, and you have some degree of lordosis. I'm not talking about deformity, I'm not talking about osteotomies. And you can go posterior and do fusion for most of the case with severe compression. I'm gonna not talk about laminoplasty. I'm gonna talk about a specific laminectomy. Most of these studies are from countries with socialized medicine, and they suggest that the effectiveness and safety of laminectomy alone without fusion is still valid, with similar efficacies between both groups, and also with less complications with laminectomy alone without instrumentation and fusion. These are two studies that shows this data, that the effectivity is quite similar with less costs. I personally do not advocate laminectomy alone for most of the cases, but my objective here is to say that this is not a procedure that it's out-fashioned or cannot be used. In selected cases, there is still a role for 1 or 2 level laminectomy. I'm going to show a couple of cases and finalize my presentations with personal tips of how to do the cervical laminectomy. That it's the objective of my presentation. Here's a patient with multi-level cervical myelopathy and alisthesis in the C7-T1, approached posteriorly with a very acceptable outcome. She has a low T1 slope, and we can address at all the levels with only a posterior approach. And also the posterior approach is useful for patients who fail anterior approach. This patient was operated elsewhere, and it persists with some posterior compression. And also foraminal stenosis, we can resolve this with posterior approach and open the foramen. Here is a case of a cervical laminectomy alone. This is a very fragile patient, older patient with good lordosis, 2-level surgery. We just do a decompression with no instrumentation, no risk of infection. And I think there's still a small role for this case. And also for compression, multi-level compression from anterior posterior without a very relevant anterior compression, you can go posterior and do a very large decompression and fusion. But what in the summary of my presentation is in the next 2 slides. How to do this procedure. The rules are expose only the levels that you'll be assessed. You don't need to expose C2 or C7 or even levels that you don't need to, you don't need to decompress or don't need to fusion. You have to try to be very carefully to not detach the muscles of C2 and C7. I usually to put the instrumentation before the decompression. Why? Most of these cases I do with the residents, and I feel more comfortable to put the screws before the compression to avoid the risk of spinal cord injury. And some exceptions is some challenging instrumentations, hemivertebra or patients with dysmorphic chains that you need to decompress to palpate it if you don't have navigation. When to perform the decompression, I like to drill bilateral laminotomies and then use a 1 or in the maximum 2 millimeter Harrison wrench. I usually to remove the bone from bottom to the top, and after the decompression to perform foraminotomies when necessary. The rod I just put after the decompression. I think I have seen some case that the rods are put in before and you can have some translation and then you can have changes in the spinal cord monitoring or even neurological depth. So put the rods after you perform your decompression. I usually to keep a good irrigation of the tissues to avoid that to maintain it moisted, and avoid to use monopolar, especially very strong monopolar, to not have the vascularized tissue. Finishing the procedure, we usually to put vancomycin and suture the muscle sheet, so we don't suture too strong the muscle itself. If you suture the muscles too strong, you can necrosis the muscles. And a multi-layer closure is of paramount importance to avoid infection and post-operative fluid collections. To finalize, the trips and tricks that we use to posterior decompression are exposed before. There is still a role for cervical laminectomy without fusion in very well selected cases, and we have to incorporate the multimodality radiological evaluation and the new radiological parameters in our decision to how to choose the best option for each patient. Thank you very much.
Thank you, Andrei, for wonderful presentation. It is very important, I think, this angio, cervical angios, and we see all of these cases very frequently in daily hospitals. And is there any questions to Andrei? We can take questions from audience.
May I ask Andrei a question?
Sure.
Andrei, thank you so much for this very good presentation. You have shown us some tricks. But my question is, I'm talking about an OPLL case, okay? Let's say the patient has compression at C4, C5, C6, okay? If the patient doesn't have any instability, okay? You have showed us some tricks, but what's your common prefer, okay? What have to be the upper and the lowest instrumented segments? You told us that you are looking to the Chimbro vertical angle, T1 slope minus cervical lordosis and the SVA. But do we have to come to C2 or can we stop at C3? I'm talking about the upper part. Or if you decompress that levels, do you stop at C7 or do you pass direct to T1? Or are you going to T2? What's your choice?
Very, very good question. Thank you. The honor for the presentation is mine. There is not too much difference for the patient in the degree of motion if you stop at C3 or C2. The point is that if you need a strong fixation, the patient has poor bone equality. I don't have navigation, so I don't put pedicles at C3. So if I need a strong fixation, the patient has poor bone quality or some disease between C2, 3, or C2 is angulated, not horizontal. I used to go to C2 with strong screw fixation, with pedicle screws. Sometimes I put pedicle and laminar screws together. The bottom level, it's a very good question. Sometimes if you have a very normal disc between C6 and C7, I try to stop at C6. if you have a very bad disc or some disease at C7 or disease at C71, I go down until T2. And why T2? Because when I put across the thoracic lamina, I don't like to put the C7 and C6 lateral mass. The screws stay too closer one from the other. So if I put C6 lateral mass, I go T1, T2. If I don't put C6, I can go C7, T1. It makes sense? Just because the screws stays, it's more difficult to put the rod if you have C6, 7, T1 together. But to go down, it's only if I need. There is a robust literature that says that you can stop at C7. Some robust, you can have to go to T1, T2. So there is no consensus. So I used to look at the case and see what I have to do. If it's a patient with high risk of failure, I go to T2, put very large screws at T1 and T2. If it's not, I can stop at C7.
And Andrei, if we're talking about cervical deformity, does it matter to go stop at, I'm talking about the lowest instrumented vertebra, okay? You're deciding according to patients. Does something is changing, stopping at T2, 3, 4? Does it matter?
For deformity, it's changed a little bit because for deformity, I made some mistakes in the past because we have to look into the cervical deformity, look into the thoracic deformity. Sometimes the apsis of the thoracic kyphosis is higher. And then in that case, I show a case very fast here that the deformity, the apsis of the kyphosis is higher. So we have to go down and we have to correct the thoracic deformity. If you have also a thoracic deformity, you have to correct it too. Otherwise, your cervical instrumentation is going to fail. And then the bottom level, if you have a deformity, you need to evaluate the rolled spine and to consider to correct both deformities. For example, if you have a thoracic kyphosis and also a cervical deformity, you have to correct this thoracic kyphosis. Otherwise, you are in high risk of failure. Is that my current experience with this?
Andrei, thank you so much for this explanations, also for the presentation.
And
thank you.
Welcome.
Yeah, there are two questions on the interview session.
One of them, Fayaz Obeyed, how many levels we can do laminectomies without fusion? Andrei, how many?
Can you repeat, please?
Yes, how many levels we can do laminectomies without fusion?
There is I went, sometimes I go to try to find this information in the literature. There is 3 levels are considered safe. I personally don't like to do 3-level lami. I think there is no robust literature to answer your question, but I believe that 1 or 2 levels it's safe. If you look at the studies that I mentioned, they do 3 or even 4 levels of cervical laminectomy. And I'm not experienced with so much levels. If I do 3-level, I fused. I think to fuse don't add too much morbidity, and because it doesn't take too much time. When I opted to not to fuse, it's in fragile patients and in older patients with as good lordosis, 1 or 2 levels. I don't do 3-level laminectomy.
And which levels between C3, C6?
It doesn't matter if it's in the subaxial cervical spine, if it's C3, 4, 4, 5, 5, 6. I don't have data to say that it's changed from C3, 4 or 4, 5. I don't have the answer for exactly the number of levels, but 3 levels, I don't think it's safe. I think you are high risk of deformity and post-operative kyphosis.
And second question, Andrei, from Alexis Dubskovich. You didn't show comparative evidence between laminectomy and laminoplasty. Could you explain?
Sure. Well, laminoplasty is a very safety and word used procedure around the world. There is some good evidence from a recent study from North America about that laminoplasty is even better than fusion. And I respect all the surgeons that do laminoplasty, but I hate laminoplasty. I don't do cervical laminoplasty. I think if you have a cord compression, you have to make the spine stiffness if you have a large decompression. And I think there is literature to support the use of cervical laminoplasty. I respect those who use this modality, but I'm not the guy to talk about this because I hate the procedure. I don't like the spine. It looks like it's not rigid and it's not strong. And I have some bad experience with tumors. You do laminoplasty and the patients hit the lamina that it's floating and you have to reapproach. So you can do cervical laminoplasty if there is no instability, if there is good indications, there is support for this, but it's not my personal choice.
Yes. A question from Yasir Taha. How long time I will use postoperative color for the patients after decompression without fusion?
Well, I think very good questions. We don't have a strong support to need brace for postoperative surgery, but in patients with high risk to failure, for example, severely osteoporotic patients, poor bone quality, rheumatoid arthritis patients, congenital children with deformities, despite the literature do not support that, I used to let them 3 months in a brace. I personally believe that in patients with right risk, to restrict movement can be useful to avoid catastrophic complications. I'm not sure that this is a scientific answer, but it's a clinical answer for you.
Thank you. And now, Professor Zileli, do you want to say something for these topics? After that, we will continue to Professor Oscar Alves' presentation.
No, we can continue. Thank you.
Okay.
Good talk.